Perfect. Okay, and the final point on this slide here is that although this morning's topic is about interstitial lung disease, and Dr. Colbourne will be here afterwards talking about interstitial lung disease as well, interstitial lung disease isn't the only way that the lungs are affected, can be affected for someone with scleroderma. The lungs can also be affected commonly with pulmonary hypertension, but I'll be focusing on interstitial lung disease today. But those two conditions are sort of the most commonly seen pulmonary complications in scleroderma clients. So I really like this diagram because it kind of shows where autoimmune related interstitial lung disease fits in with the big picture of interstitial lung disease. And interstitial lung disease is kind of really a descriptive umbrella term. In fact, there are thousands and thousands of ways that or different types of conditions and diseases that are termed interstitial lung diseases. And within that falls fibrotic type interstitial lung diseases, or interstitial lung diseases that are affected by scarring to the interstitium, and I'll show that in a second here. We see sort of all these types of interstitial lung diseases in pulmonary rehab with different causes. There are smoking related ones. Hypersensitivity pneumonitis is just sort of a fancy way of saying sort of allergen related one, like the allergic process in the lungs. There are interstitial lung diseases caused by specific medications as well. There are interstitial lung diseases caused by occupational exposures. And there are interstitial lung disease is, in fact, a big subset that we don't know the cause of. And so in that case, we term them idiopathic. We don't know what causes them. So scleroderma-related interstitial lung disease falls into this category here, and you could break down that category even further. Perhaps the most common autoimmune condition related interstitial lung disease we see in pulmonary rehab relates to rheumatoid arthritis, and that's just because it's likely more of a common diagnosis than scleroderma. But I've also seen several clients over the years with scleroderma as well, Sjogren's syndrome, lupus, so those would all fall within the category of autoimmune related. So when I start to talk a little bit about why pulmonary rehab and exercise in general can be seen as a therapy for someone with interstitial lung diseases, I won't go too much into the science of it because I know Dr. Colbourne's speaking later, but this is a good diagram to sort of show where oxygen exchange happens in the body, and that's really across the interstitium. So when we hear the term interstitial lung disease, what is the interstitium really? Well, it's this thin tissue wall. So it just means sort of a wall of tissue that exists between our airway. So at the bottom of our airway, we have these little tiny sort of grape-like sacs that are called alveoli. Very thin, kind of like little tiny balloons, very stretchy. We breathe oxygen in, it comes all the way down through our airways. It kind of branches off like a tree, sort of millions and millions of times, to these small grape-like sacs that inflate with air. And that's really where the magic of breathing happens, so to speak, in the body, is oxygen has to pass across from the alveoli through this thin tissue wall, which is the interstitium of the lungs, the actual tissue of the lungs. And then it has to be picked up in the blood vessels, those very small blood vessels in the lungs that then carry the oxygen throughout the body to our muscles. So when we're talking about interstitial lung disease, that area of tissue there, particularly in scleroderma, it's what happens when collagen sort of gets laid down in excess in the lungs, and it affects the tissue there. It makes it thicker, so it slows down the time it takes for the oxygen to get across, and then consequently we breathe out carbon dioxide into the air that's carried from the blood up to the lungs, and it slows down the time it takes for carbon dioxide to get out. So we call that process diffusion across the tissue wall, and that, when there's scarring and inflammation in that point, slows down that process. Why that's important for exercise and movement particularly is when we're at rest, our blood is not moving too fast throughout the body because our heart's not beating really fast. When we start to move and exert ourselves, like climbing up the stairs or going for a brisk walk or something like that, our blood starts to pump more quickly through the lungs. And if there's sort of a time lag, sorry, I'll move for the people who Zoom, sorry about that. If there's a time lag through that gap, the blood doesn't have time to pick up the oxygen. And that's very critical for why people with interstitial lung diseases become short of breath, especially with movement. And that's common really to all interstitial lung diseases where that tissue wall is affected. So specifically scleroderma-related interstitial lung disease, as I said, the lungs can affect up to 80% of people with scleroderma. Fibrosis and inflammation, well, if you think of the inflammation like sort of the autoimmune manifestation of the autoimmune response, kind of like the body sort of attacking the lungs, so to speak. It can start with inflammation, but then over time, the more inflammation we have going on anywhere in the body, that's kind of like the body's healing system on overdrive, right? It's trying to heal, lay down more collagen, and it kind of goes sort of out of control more than what the body needs. That eventually over time leads to scar tissue. And that's what the word fibrosis means, is scarring in the lungs. And that's why it's so important that even if you're noticing changes in your breathing or your exercise tolerance early on, that you tell your primary care provider. Because immunosuppressive therapies can, if they're started early and medications started early, it can hopefully slow down that process of scarring in the lungs. When fibrosis happens in the lungs, when pulmonary fibrosis occurs, literally the lungs become stiffer, right? So normally the lungs are very loose and elastic like a balloon. And when scar tissue happens in the lungs, it takes more energy to inflate, kind of like an old accordion that's been sitting in the attic for many years, right? It's not going to be as pliable, as supple. So our work of breathing increases. And our capacity for taking a large volume breath, stretching out the lungs, is reduced over time, and that can be measured with pulmonary function tests. Some of the symptoms that may start to occur, and these symptoms of interstitial lung disease really can start very insidiously, very slowly over the years. It's not like something acute, like an asthma attack or something like that happens. Symptoms include shortness of breath, first on exertion, and then perhaps in more advanced stages at rest. Another word for shortness of breath is dyspnea. A dry cough. In interstitial lung disease, the cough isn't typically like a wet, productive cough of mucus, unless there's a chest infection or something like that. It's usually a sort of a nagging, deep, or irritating dry cough. Fatigue is a symptom of interstitial lung disease, again, for many reasons, but one mainly is the body's requiring more work to breathe, more energy to breathe. Chest discomfort or tightness can often be felt, again, because of that stiffness and more work of breathing. And another sign we sometimes see, not always though, but it's usually associated with pulmonary fibrosis, is clubbing of the fingertips. And that is what that looks like when you get some rounding of the fingertips. So that's a sign we can look for on assessment. So for anyone who has shortness of breath in the context of a chronic lung condition like interstitial lung disease, exercise is particularly important. And this is a slide I show the clients who come into pulmonary rehab when I'm sort of selling the importance of exercise for anyone that's breathless. And we call this the cycle of deconditioning. So what happens when we feel short of breath with activities, even slowly and subconsciously, we start to avoid anything that provokes that feeling, because as human beings, being short of breath is, well, we'll put it this way, when you can't catch your breath, that's a very anxiety-provoking feeling in our brain. So we start to avoid activities that bring on that feeling, and you may not even notice you stop taking the stairs or something like that, or you just do less. But what happens over time when we do less is our muscles and our heart and our oxygen delivery system in the body become weaker and less efficient. And that really is key. So when people ask, well, why are you making me do so many leg and arm exercises in pulmonary rehab? I thought this was about the lungs, right? When our muscles become weaker and less efficient, they tire quickly, obviously, we know that. But they also produce more sort of waste products of the type of energy use that doesn't use oxygen. So they produce more CO2, and they produce more lactic acid, you know, that sore feeling you get if you haven't exercised in a while. That's a lactic acid feeling in the muscles. When they're inefficient and we have more CO2, guess what system has to offload that CO2? It's the lungs, right? So with weaker muscles, you're putting more strain on your lungs to breathe more, right? And for someone with an underlying respiratory condition, that's particularly important. So that is why exercise is such an important therapy for anyone with chronic breathing symptoms, because this cycle can be reversed. And that really is what pulmonary rehab is all about. Other benefits of exercise, so certainly helps manage symptoms. It doesn't change what's happening in the lungs physically, and that's the same for any lung condition that I see. We can't go in and fix the lungs, but we can fix or manage everything outside the lungs as far as oxygen delivery goes, and that is very important for symptom management. Helps the body and the muscles use oxygen well, and the heart. Prevents loss of walking distance and function. And that's the biggest piece, I think, as far as goal development in pulmonary rehab, is not losing those functional activities. Improves overall energy levels by improving fatigue and stamina. Improves overall quality of life because you're able to do those tasks and things that you want to do in your life that do require energy. And it helps improve balance and prevent falls. Exercise in scleroderma specifically, interestingly, when I did a bit of a literature, a research scan, direct evidence is limited. There was one sort of big systematic review, and overall it found that exercise is described as safe and studies indicate a positive effect. More studies are needed to determine the best timing, the best type and dosage of exercise specifically in scleroderma. But sort of take that with a grain of salt, because if we're talking about scleroderma associated with interstitial lung disease and chronic lung conditions, there is a plethora of more evidence regarding the benefits of exercise in lung conditions associated with pulmonary rehab. People with interstitial lung disease can exercise safely, and that's sort of one of the maybe the fears or concerns when people are thinking about exercise or even coming into a rehab program is, if I'm breathless, how do I exercise? Am I putting too much strain on my heart, on my lungs, on my body? But the benefits of exercise, again, sort of outweigh concerns like regarding heart and things like that. But a few things to keep in mind are having medical guidance to start, and that's where pulmonary rehab comes in, because everyone's unique. Being aware of your limits and progressing slowly. And so that's one of the things we also see too when people try to adopt an exercise program at home when they do have symptoms of breathless, is we do too much too soon and the body's not conditioned and ready for that. So we have some sort of setbacks, right? The breathlessness gets, flares, or we get sore muscles because we're doing too much too soon. The body really responds best to a slow, progressive introduction of exercise over time so that it has time to adapt. It takes about usually 6 to 8 weeks, so it's not like a quick fix, right? Also knowing how exercise should feel, what is okay, what is not, and we teach that in rehab, and when to stop and rest. So knowing all of that, what is pulmonary rehabilitation when we think of that as an intervention? So really, it is a medically supervised program of exercise and education for people living with a chronic lung disease. The goals include helping people manage their symptoms well, improving their exercise tolerance, improving their quality of life, which we actually take measurement of before and after, and certainly improving overall function for daily activities in conversation with the client and their specific goals. So here's some quotes from participants. I'm able to move more. I started with housework. Now I'm able to walk from the basement to the second floor without stopping. And we often don't think about how much energy certain tasks take just in our household environment. Some of the biggest ones are stair climbing, because we're going right against gravity and we're using the big muscles. So if those muscles aren't conditioned, guess what's working to sort of compensate for that? Our lungs. And things that involve the upper body push-pull, vacuuming, is a big one. Even sometimes changing the bed sheets, like trying to get the bed sheets over the corners, things like that. The upper body muscles are also breathing muscles, right? So when we have to use our arms carrying things, and never mind carrying things up the stairs, then you're combining everything together. So our goal is to make tasks like that not seem like it's maximizing people's tolerance at home, and that can be done through conditioning. Another quote, feeling less breathless and being able to accomplish more makes me less anxious. And I always just put up this graphic here because what we talk about in rehab too is really the link between feeling any sort of breathlessness and how that triggers anxiety and panic in the brain. So we see a lot of folks who come into our program who even just the anticipation of having to walk or feel breathless, that sort of triggers their breathing even more in this vicious cycle because the mind and body is so linked when it comes to breathing. So that's another aspect of the program we look at. You may be wondering what healthcare providers are involved in a pulmonary rehab program. So certainly physiotherapists, so I'm full-time in the program at Deer Lodge. We also have a respiratory therapist. We have a pharmacist with the program, a dietitian, a social worker, and a respirologist. So that's a lung specialist who sometimes, will either see clients or consult with us if we have questions or need specific orders and things like that. So if you're referred to pulmonary rehab, the assessment will typically involve or will be with the physiotherapist, myself, and the respiratory therapist. We take a lot of time for assessment with our clients, usually about 1 to 2 hours seeing both of us, because we really like to get to know our clients and their unique situation. We'll take a sort of a full medical history from you. The respiratory therapists will do breathing tests if necessary, but usually those may be even done before the point that someone comes to see us. And so we can kind of see those already, especially if you are feeling something is not quite right with my breathing, you should tell your doctor and then be referred to a respirologist if possible. The respiratory therapist and myself can do an oxygen assessment. We assess endurance. What we use is a 6-minute walking test before and after the program, and that's sort of a key outcome measure to assess functional exercise tolerance. We'll assess strength, range of motion, and pain in preparation for getting someone ready for an exercise program to see if there's any sorts of exercises or movements that wouldn't be indicated for that person. As I said, we take quality of life measurements that you sort of fill out on paper and go over your specific goals. Like everyone's case is so unique and everyone's presentations of symptoms are unique. So we'll ask, what is getting difficult at home? What would you like to work on? What sort of do you expect from the program? So it's kind of a team effort. And then our assessment information is used to develop an individualized exercise and education plan for the person. And we try to be as individualized as possible in pulmonary rehab. So someone coming into the program with scleroderma-related interstitial lung disease would be no different in that. So some special considerations for exercise therapy, or even if you're thinking of increasing your physical activity at home, these are some things to be aware of. Certainly inflammation that occurs throughout the body can have an effect on our joints, joint pain, and joint deformity, limitations in range of motion due to inflammation in the joints. So choosing appropriate exercises for that. Some people with scleroderma may present with muscle pain or even myositis. So that's why having that medical guidance and having a physiotherapist involved with the program may be beneficial to guide you on exercises. Sometimes in our hands, we may have bone resorption, right? So even our grip might be affected, right? Osteoporosis may be something to consider as well. So safe exercises for the spine, balance exercises, taking into account bone safe exercises, and also appropriate exercises like weight-bearing exercises is really good for bone density as well. Heart conditions, so we would do an assessment to make sure someone is okay as far as being stable from a cardiac perspective, and in some cases we may connect those dots and refer out to a cardiologist as well. And then the biggest thing we're looking at safety-wise is looking at someone's oxygen level during the program, because everyone with interstitial lung disease may be different as far as how low their oxygen drops with exertion. And so then we would tailor the program, their exercise intensity to meet that. Good. Types of exercise we use in pulmonary rehab. Aerobic training is kind of like the sort of foundational type of exercise that we use. And that's just a fancy way of saying sort of cardiovascular training. That's the type of exercise that improves endurance, right? That improves the body and the big muscles' ability to move and go for longer, which is very important for oxygen use and the respiratory system. I'll go into that a little bit more in a second. Resistance training means strengthening exercises, so making the muscles physically stronger for the tasks that they're doing. And then flexibility and balance exercises, which are also really good for the joints and muscles. So the word aerobic means helping your body use oxygen well. And aerobic exercise is beneficial for everybody, young and old, but specifically certainly for people with any kind of lung condition. Some examples of aerobic exercise include walking. Walking is probably the most functional because we have to do it all the time. So we don't want to lose our body's ability to walk distances. We want to maintain that. Walking can be done in our hallway on a flat surface, or some people are using the treadmill we use quite frequently. An exercise bike is an example, and the favorite machine at pulmonary rehab is called the New Step, which is kind of like a seated stepping machine, so getting your muscles involved even in a different way than walking. So those are all examples of the types of exercises we use. This is just an example of sort of how we help people gauge, how hard they're working in pulmonary rehab. We call this an exertion scale, and we teach people to use it at home. And it's something even to think about when you're doing your daily tasks at home is, how would I rate my breathing effort with this task? If we're doing vacuuming and we're rating it up at a 9, 10, that might be, something to consider. Should my breathing be this hard with this activity? But when we're exercising and working on endurance, we train people, you should be able to sort of talk while you're exercising. You shouldn't feel like you're gasping for breath, or, it shouldn't feel like an emergency situation. We don't want to push the heart and lungs too hard, and nobody can sustain exercise at about a 9, 10 for too long, right? But we want to work on improving endurance sort of in this moderate range. You're breathing heavily, which is normal during exercise, to notice you're breathing a little bit, but you can still talk, have a conversation, that type of thing. We teach people how to manage aerobic exercise with tips and tricks, body positioning to help reduce breathlessness. So helping people tolerate their breathlessness a little bit better. These are just some examples of the things we teach. Putting the body in the lungs in a lean forward position, which gives the breathing muscles more space and sort of efficiency to work really well. So there's many sorts of strategies that one can use if they're breathless to sort of manage that breathlessness with exercise. Some people, we may use gait aids to promote their walking. If people are on supplemental oxygen, we can get sort of walkers or rollators with holders. And actually leaning forward on something, just like I showed in the previous slide there, leaning forward on something for walking really helps us lower the energy costs of walking. So it helps people walk farther. So you may notice sometimes when you use a cart or something like that, you're actually able to walk farther because you're breathing a little bit easier. So as I said, resistance exercise builds stronger muscles and bones. In rehab, we really keep it individualized, as I said, but also very simple, okay? So we don't do sort of any overly complex type of exercises. We really promote using simple tools that people can then continue with sort of as a lifestyle change at home, right? So some examples of things we might use include a chair for sitting and standing exercises, depending on client needs. Some little hand weights, which are always great to have at home for exercise. If people don't have hand weights, we'll usually start by just saying, grab some soup cans and do the exercises. Or if there's joint problems and things like that, we might say, just do range of motion exercises and prescribe those. And then exercise bands are particularly a useful tool for exercising the chest and back. And all of those muscles are involved in breathing. And when we're breathless, sort of opening up the chest even more. So for someone with interstitial lung disease who has sort of a stiffer lungs, it's particularly important to strengthen the back and upper chest. So lots of exercises with bands in pulmonary rehab. This is my student from last year. I always have PT students with me, so just demonstrating the types of exercises. And depending on where someone is at coming into the program, we have people who are more advanced and are exercising at home. We have people who are, functionally capable, but maybe just starting from pretty much a sedentary type lifestyle and then starting. And then we have people who may be more severe and find it difficult to even walk short distances or lift. So we really have a sort of a wide variety of clients. So we really adapt the program so that it's appropriate. So even starting with just some seated exercises, following up to see how those exercises felt, is there any joint pain? How did you tolerate it? That sort of thing. Leg straightening or working the muscles of the legs, particularly important, sit to stand type exercise or stepping up on a stair and making it as functional as possible. As far as strengthening and breathing goes, we think about the arms and legs, which is important, but it's also very important to target the core when we're designing an exercise program for breathing. Our big breathing muscle, that diaphragm, which sits right here, is actually the top of our core. The bottom of the core is sort of our pelvic floor, and then our abdominal muscles sort of wrap around like this. So really our abdominal muscles and even our pelvic floor support the work of the major breathing muscle, which is kind of that top part. So lots and lots of core work or prescribing core exercises. Like this is a simple one called a bridge, which also targets most of the muscles of the body. So core exercise is particularly important for breathing and shortness of breath. And then just some examples of stretching and balance exercises. This is a common balance exercise called a tandem stance, working on balance, challenging all the muscles, and other benefits as far as if those are affected by osteoporosis and things like that associated with their interstitial lung disease. Stretching to keep the muscles of the chest and the joints of the chest mobile and moving. If the joints of our rib cage and our chest also become stiff or inflamed, the body has to work even harder to stretch the chest and move. So mobility of the chest wall, of the spine is particularly important. And here's just an example of sort of a group stretching class for the lower legs. So exercise is one major component of pulmonary rehab that I'm involved in, but I also want to touch in to end off here some of the educational components, because I feel those components are equally as valuable and involve many of our other team members on the team. The goal of pulmonary rehab is really not just to learn to exercise when someone's supervising, although that's easy from a habit perspective. The goal is to implement lifestyle changes after the program and continue with those lifestyle changes. So certainly ways to manage symptoms, different tips and tricks I've talked about, how to exercise at home. So everyone who goes through the program would get home recommendations as well, or a home exercise program to continue with. Preparing for health visits. What to expect, what questions to ask when you go to a doctor, or if you ever find yourself having to go to the ER or something like that for breathing symptoms. That's part of what we would teach. Oxygen use. There's a big educational component and questions when people are on supplemental oxygen, how to use it safely at home, how to manage it if I want to travel with my oxygen and things like that. What setting should it be on? So that's sort of the part that the respiratory therapist is involved in, as well as myself. Medications, and perhaps Dr. Colbourne will dive more into this. Certainly it's not my direct wheelhouse, but of course there's immunosuppressive therapies that when, scleroderma is affecting the lungs, that some may be on. But now are these antifibrotic medications that are slowly coming out. And they were first used with idiopathic pulmonary fibrosis, but now they have other indications. So I'll leave that for him to touch on. But the important thing about our team is that we have a pharmacist who's kind of like the expert in all these different types of medications that relate to the lungs. And so she's there on our team to answer as many questions as she can and do education sessions as well. The dietitian, of course, talks about healthy eating, and weight management is particularly important for breathing from both ends. So if someone is overweight, has a lot of weight around the chest wall, that puts more sort of force on the chest wall, so it's harder to breathe. But if someone is underweight too, and that often happens if our work of breathing is harder, we're actually burning more calories all the time with our breathing. And so being underweight has its own challenges as well for function and breathing. Oopsies, going backwards there. And then coping strategies. So our social worker with the program does several education sessions on, future planning, how to cope with change in functioning, how to cope with some of the financial implications of sort of a change in health status, navigating income, navigating, disability tax credit and things like that. So that's another sort of whole psychosocial aspect that the social worker can provide. Some of the key educational considerations for clients in PR with scleroderma-related ILD might include, well, this may be for everyone, of course, if smoking, work towards quitting. And that's something that we also provide in the program. We do take people who may be trying to quit smoking as well in the pulmonary rehab program, and we'll provide them with some behavioral support, behavioral guidance for working towards quitting. Avoiding secondhand smoke and other respiratory triggers, managing gastroesophageal reflux disease. So, and this goes for sort of that whole bubble of people with interstitial lung disease as well. But anyone who has fibrosis in the lungs, we often see that sort of co-occur with what's called GERD or reflux, and that can hasten or exacerbate that fibrosis in the lungs. So it's very important to manage esophagus problems to avoid aspiration into the lungs. Reminding people not to ignore symptoms. And the interesting thing about, or the unfortunate thing about interstitial lung disease is sometimes, the process is occurring in the body before the symptoms sort of get to our level of being severe enough to talk to the doctor, right? So it's important that, you're having those conversations, even perhaps before you're experiencing any symptoms, just to make sure that screening is done. And then we also cover what we call action planning and self-advocacy. And what we do for clients with interstitial lung disease is, what to do if suddenly you experience your symptoms getting worse. That's sort of a different conversation than someone with COPD whose symptoms all of a sudden get worse. It's a sort of a different approach to what should I do in that situation. So we actually teach people what to say, what to do, and provide it in writing should they have to go to the ER with sort of a breathing related exacerbation, because often people with interstitial lung disease can be mistaken for people with COPD and vice versa. So that's a pretty important educational piece. So I'll specifically talk about pulmonary rehab in Manitoba. I probably have some questions specifically in mind. So we are an 8-week outpatient program. People attend twice a week for their rehab, generally for, as I said, about 1 hour to 2 hours. We have different options, morning or afternoons, and we have 3 program sites throughout the city. So of course, I work at Deer Lodge. We also have a program site at Misericordia Health Center, and then the Wellness Institute at Seven Oaks. But we have one centralized referral service or intake coordinator. So depending on where people live in the city, that referral is directed to the program site. So hopefully you get connected to Oopsies, a site where you live close to is the ideal idea. And we have different ways of delivering pulmonary rehab. Traditionally, pulmonary rehab is done in a small group setting. So that's kind of a nice aspect of it too, is that you're sort of meeting others with the same condition. A lot of peer learning goes on, a lot of sharing, support, things like that. And what we actually try to do at Deer Lodge, because the majority of the diagnosis we see is actually COPD, but over time, we've realized that people with interstitial lung diseases have unique needs, as I said. So we actually try to cohort or group people with interstitial lung disease together in their learning groups, in their rehab groups. Now, COVID kind of knocked all that off its plan when we had groups. So we sort of went to more of an individualized rehab model. But now here we are 2 years later, and this fall we're just getting back to our small groups. It's just like we're getting back to in-person, which is really ideal. And we also have virtual options too. So we use Teams, not Zoom, but we can do sort of a virtual meetings, virtual assessments, take a history, things like that. And that comes into play, especially when people are outside the province or outside the city. Oopsies. Oh, here we go. Just glitched for a sec. There we go. So just some frequently asked questions that might be on your mind, and then I'll certainly pause and take some more. Is there a cost to attend pulmonary rehab in Manitoba? No, there's not. So if you know about cardiac rehab, so that's a program that there actually is a cost to attend. But for our program, that's sort of part of the WHA. There's no cost to participants to attend. And I guess the reasoning sort of behind that is, we're providing sort of preventative self-management care that hopefully keeps people well, living well for as long as possible, hopefully not deteriorating in their health for their need to go to the ER and things like that. No. Do we supply oxygen? Yes. So if people are on supplemental oxygen, and that's a whole other conversation and associated with the costs of having portable oxygen and tanks or concentrators and things like that. So we do switch people to our oxygen and supply that during the program. Not everyone who comes to the program is on oxygen, certainly. It's really a mix. Can a support person attend with me? Yes, of course. We actually encourage that, just like in support groups, just like at events like this. It's always beneficial to have your support person have a second set of ears to hear those teaching points, and many benefits to that, of course. And what if I live outside of Winnipeg? I know we get kind of, all the services are just so close to the border always. As far as I know, the only programs running right now are in Winnipeg. Brandon used to be running one, but I think that kind of died down with the pandemic. I'm not sure if anyone came from out of Winnipeg today, or there might be some listening on Zoom. But even if you live outside of Winnipeg, still talk to your doctor about a referral to pulmonary, because we can be creative with how we at least reach people, provide individualized service, provide even a phone call or a virtual assessment and meeting, and provide some guidance even for a home program. Because ultimately, pulmonary rehab principles can be applied at home as far as exercise go with the right type of tools and equipment. So how do I access pulmonary rehab? Well, here's our intake line here for any questions. Lorna, our intake coordinator, loves to take questions, and she's very friendly. She's happy to answer any questions. I always warn her on Monday when I do like group education, you may get some calls, so she's ready. I would say first speak to your primary care provider and have that conversation, but sometimes they may have not even heard of. Sorry, yeah. Oh, yes, I'm on the side, sorry, and I'll read it out for Zoom. And I'll also provide, the pamphlets, but the number is 204, I'm standing 831-2181. Again, 204-831-2181 is the intake coordinator line. But have a conversation and, be prepared for a little self-advocacy sometimes, because a lot of primary care providers may not have even heard of our program. So that's why we like to do talks like this, to get the word out there. If someone already has a respirologist who's a lung specialist, typically they are, they know about pulmonary rehab and they'll be happy to have that conversation. But sometimes it comes down to people who are not accessing our program. It's not because they don't need it, it's because no one has offered the service to them. And they're feeling, as someone said at the beginning, like kind of lost in what is out there for me, right? With these rare conditions. So certainly have that conversation. And I have brought today a stack of our referral forms just on the front table here. They're also available online, and also a stack of our program pamphlets. And sorry, this number will be right on the program pamphlet as well. So feel free to take that today. Good. I hope I've not gone too far and that I've left a little bit of time for some questions. So I'm happy to take any, whether they're on Zoom or in-house. Thank you very much. That's a great question. Everyone always asks that question about the waiting list. The answer is yes, there is a waiting list. We probably could use one or two more outpatient rehab sites. And depending on the site, our waiting list might vary. What we do at Deer Lodge Center, sorry, I'll repeat the question for the Zoom. Is there a waiting list? I think I did, but at Deer Lodge, what we will do, the way we sort of operate is when we get the referral sent to us from the intake coordinator, we'll try and contact you right away, with the person right away, even by phone, just to sort of see what your situation is. I do like a mini interview over the phone. And we try to book our assessments actually as quick as possible. Then there may be, depending on sort of what the needs are, or the acuity of the person, or if they've just come out of hospital or something like that, that may change the priority status of wanting to get someone into a rehab program. Like if someone's imminently functionally deteriorating, or if they're at high risk for going back into the hospital for some reason, like chest infections and things like that. But we typically try and get people into the rehab program, the 8-week program, within 4 to 6 months. But the assessment can actually happen a lot sooner than that. I'll just stop sharing the screen for a second, if that's okay, so I can see the participants too. There we go. Good. Any other questions at all? Yes, in the back there. Yeah, that's a really good question. So just to repeat, the question was, with interstitial lung disease, is there a bit of like more of a, I guess, time needed for warm up of the lungs? And do you ever see the shortness of breath initially, and then maybe it taper off a little bit towards the end? I think that's even, I think yes, in a way. Because the muscles of respiration do take a warm-up period. So that's one of the principles of exercise in general, is that your body needs a little bit of like low intensity exercise to warm up. So if you start hard right away, you will feel more short of breath as sort of your body catches up with blowing off all that CO2 and everything like that. I'm not sure the direct answer for interstitial lung disease in particular, but I would say certainly warm up, like a 5 to 10 minute low impact warm up, is particularly important for any of our clients in pulmonary rehab. And what they find over time, over subsequent aerobic sessions, is that shortness of breath with that, whatever that activity is that they're continuing to do, becomes more manageable as the body's endurance slowly improves. But I would say, yeah, I don't know if that's a super great answer, but I would say, yeah, you're right. It's particularly important. And sometimes shortness of breath does level off once sort of blood starts pumping in the body. Yeah. Makes sense. Yeah. Yeah. Yeah, oh, that's a really good question. So as far as like the joints and the muscles, and certainly those can feel stiff at first, but yeah, the more you sort of work them and the more blood flow through movement comes to the muscles, they become less stiff. I think that could certainly be applied to at least the joints and muscles of the chest wall. It may feel stiff, when you start, right? And then once the movement happens, you may find it improves. That makes sense to me. Yeah, good question. Any other questions? Oh, yes, right there. That is very interesting. I think it's been particularly challenging, the masking, certainly for our clients, because on the one hand, you want to protect because, immunocompromised, you might be immunocompromised, but on the other hand, exercising with another barrier when there's already a barrier in the chest is, yeah, it's difficult. Oh, that's interesting. Good. Yes. as far as interstitial lung disease specifically. Oh yeah, that is putting me on the spot. Or interstitial lung disease with scleroderma. Oh yes, absolutely. So the question was latest research in Manitoba, specifically on interstitial lung disease. Oh, I don't know. I don't know specifically in Manitoba. Sometimes we lack a little bit on research, but I'm not sure. On interstitial lung disease. In Canada, I'm not too sure. The one I read was in 2019, was a systematic review. Like interstitial lung disease is such a broad area. So there's lots and lots of research being done in idiopathic. Yes. And to be honest, that's sort of like a little bit of has been my focus, because I'll be honest, out of all the interstitial lung diseases we see in pulmonary rehab, the biggest proportion is idiopathic. And idiopathic can also have a bit of a poorer prognosis. And that type of interstitial lung disease is the one that these new antifibrotics have been targeted at. So you may have heard of Ofev or Esbriet, those sort of within the last 5 to 10 years. So I've noticed since the drugs have come on the market, of course, then there's pharmaceutical money for research. So there's been more and more in like clinical trials as far as medications. But as far as for us in rehab, there's robust evidence for pulmonary rehab in COPD. Like it's almost like a proven benefits and outcomes. It's harder to study that in ILD because of the variability of all the diagnosis in that umbrella. And it's probably even more scant and lacking in autoimmune. But yeah, that's a good question. Yeah. Any other questions? No, none in the room, none on Zoom that are coming up? No? Okay. All right. Thank you very much, everyone.
Thank you very much for the kind introduction. I imagine it's better if I take my mask off while I'm up here, so you can do a little lip reading. Okay. Just want to make sure that's okay with the group. It's a pleasure to be here, an honor to have been invited to speak about pulmonary disease in systemic sclerosis or scleroderma. My batteries are pretty low today, so I apologize in advance if I seem like I'm running on empty, because it's true. I had an early hockey game, and I feel like I haven't warmed up from it. I was in the stands, not playing with watching my kids. In any case, I was invited here to talk about pulmonary disease in scleroderma. I'm never really sure what a group hopes to get when I come to speak, and I've not been, associated with the group before. So just want to confirm that I imagine most members are patients or supports of patients. Is that accurate? Okay. So I have about 25 or 30 slides in here, mostly broad strokes. It is a very complicated topic with a lot of depth that we could go into, but my hope is to entertain some questions, and I also recognize based on the time slot that I'm probably standing between you and lunch, and that's always a tough place to be as a speaker. Again, a pleasure to be here. The title of this slide is Pulmonary Complications, but it probably should say Pulmonary Manifestations. As you know, scleroderma is not a single system disease, and oftentimes, at least in my practice, I see it as a first manifestation in the lung, and we ultimately make diagnoses of this multi-organ pathology having began as a lung disease, so very much a part of my practice. So as was mentioned in the intro, I am subspecialty trained in interstitial lung disease through the University Health Network in Toronto, and I returned to Manitoba about a year ago after having worked here before that and trained here for several years before that. Which allowed me to go away with the support of the University of Manitoba and gain some additional training experience in this realm of interstitial lung disease, which is, I imagine, why I was specifically invited as far as my respiratory colleagues and I go. So I'm the only interstitial lung disease specifically trained person in the province. Now, I don't know if I have any patients in the room just scanning, but I'm sure many of you have had interactions with respirologists, and certainly there's a lot of expertise in the province of Manitoba already. But they did want me to specifically train in that area and then start the ILD clinic at Health Sciences Center. It's been a bit of a, I guess, struggle, we'll say. There's been lots of change in the healthcare system, and Health Sciences Center has been no stranger to that. So we moved our clinic space kind of in the springtime, and it's been a very tiring process for lots of us as healthcare workers. I think it's all going to be for the better in the long run. But it's just interesting to be part of organization change. And I think we have a lot of vision for this ILD clinic specifically. And some of that I hope to one day include actually multidisciplinary clinics with rheumatology actually embedded within a respiratory clinic or vice versa. That's a model that exists in a lot of other provinces, including the one that I trained in. And I've seen it quite successful and great for, moving patient care along as far as connective tissue disease and associated interstitial lung disease is concerned. So just putting a plug in for what I hope will be, great improvements in terms of how we approach this disease in Manitoba and in years to come. With that said, what I'm hoping to talk about today is a little bit more about the pulmonary manifestations of scleroderma, including diagnoses, patient experience of those manifestations, and the treatment options we have today, which are, expanding year by year. And as I said, I'm hoping to have a lot of time to answer any questions that you might have for me. Spend a little bit of time on the slide. This is effectively what the pulmonary manifestations of scleroderma look like. At the top of the list is my area of expertise, as I mentioned, interstitial lung disease. Next to that is probably pulmonary hypertension. So I'm going to talk a little bit more about those two. The ones that are further down the list are more rare. All of these actually interplay with each other. So you can certainly have more than one manifestation. And for example, aspiration has a great impact on the development and the development and prognosis and worsening of interstitial lung disease. Similarly, you can have pulmonary hypertension that is strictly because you have another pulmonary disease like interstitial lung disease. So there's lots of interplay between these different diagnoses. While I'm on this slide, I'll mention, as I'm sure you all know, gastric and esophageal motility are an issue with scleroderma, and that has an impact on lungs. So, the aspiration of gastric contents or gastric acid can lead to what's called a pneumonitis, or an inflammatory reaction within the lungs. Over time, if unmitigated, this can result in scarring and more of a chronic lung disease picture. And as well, it can cause infectious complications such as pneumonia. I mentioned drug-induced interstitial lung disease because some of the medications that we use to treat connective tissue diseases, and scleroderma is no different, can actually cause lung disease themselves. So sometimes when I'm first seeing a patient who has interstitial lung disease, I'm not sure if it's the medications they're on to treat their other manifestations of that illness in the body that's causing the lung problems, or if it's the illness itself. And that can be a very difficult situation to sort out. Other things that are much more rare, so pulmonary embolisms or clots in the lungs. So there is a higher association of clotting in general with scleroderma and connective tissue diseases. So it's possible for people to get these clots in their lungs, which can be, quite a dramatic event. Pleural effusions are very rare. So pleural effusions are collections of fluid that exist within the chest but outside the lung. Quite a common scenario we find ourselves in, but a rare manifestation of scleroderma. Similarly, airways disease, not typically associated with it. I think this probably relates to some of the things above it. But when I say airways disease, I mean things like what COPD would look like. So more of an obstructive inhaler responsive type of disease. And then very rarely we can see respiratory muscle weakness. So that sort of has further impact on the vital capacity and the ability for one to take deep breaths, which is one of the things that we see with interstitial lung disease. So as I say, lots of interplay between these. I'm going to talk a little bit about pulmonary hypertension first. I would say it's the second most common type of pulmonary manifestation of scleroderma. And just to kind of go over this, I hope you can see my marker a little bit here. Sorry, I don't have a reference for this picture, but it came from Google Images. I thought it was a really good, demonstration of what we see. So on the left, you see the normal situation where we're talking about the right heart here. So when we think about hypertension or high blood pressure, typically you're thinking about the left heart. That's the part of the heart that pumps oxygenated blood out to the body. So that's where these red chambers are. When we're talking about pulmonary hypertension, we're talking about high blood pressure within the lung vessels. So that's the right one. So that's the blue deoxygenated blood. So the blood returns via the inferior and superior vena cava from the body, so deoxygenated after passing oxygen off to the organs all over our body, enters the right heart, and then it's pumped out through the pulmonary artery into the pulmonary vasculature where it's meant to pick up oxygen and then return to the left heart where it's then pumped out again. In pulmonary hypertension, for various different reasons, what happens is that these vessels get stiff. So basically the wall of the vessel can become very thick. You get smooth muscle dysfunction or thickening there, and they don't relax the way that they're supposed to in response to blood passing through them. Or you can have clots, so they actually have obstruction because of the pulmonary embolism issue that I mentioned before, which is sometimes seen as scleroderma. And as a result of that thickening, that pressure backs up. What ends up happening is over time, if again untreated, the right heart will become stiff and not pump as well, and you'll start to get heart failure effectively, which results in blood flow not going the way it's supposed to, and then you get fluid buildup in the body. So this is one of the things that we can see with scleroderma. We categorize pulmonary hypertension according to groups, and the one that is the most sort of treatable directly would be the pulmonary arterial hypertension, which is group 1. So this can be an idiopathic manifestation in patients, and that's probably the thing that is most researched, but that is what's considered the primary pathophysiologic consequence of scleroderma. And so the treatments that we use with disease where we don't have an underlying cause are the same treatments that we use in scleroderma-associated pulmonary hypertension. But all of these other things are also relevant considerations for scleroderma. So group 2 disease is when you get cardiac disease. So I know this isn't a talk about heart disease, but certainly there are cardiac manifestations of scleroderma as well. So if the left heart doesn't pump as well, it results in a backup of pressure into the right heart. Group 3 is relating to chronic hypoxia. So for example, if you have interstitial lung disease, which I'll talk about, and the manifestation of that results in your oxygen levels being too low over time, that low oxygen consequence is that these vessels get stiff, and it results in pulmonary hypertension. Group 4 relating to that thromboembolic disease. So if your scleroderma is resulting in you having clots and you don't treat those clots properly, again, those chronic obstructive defects result in that pressure getting high. So very complicated, but all that to say that it does take, again, sometimes a multidisciplinary focus to sort of what exactly is causing pulmonary hypertension in scleroderma. Within the respiratory clinics where this is dealt with, and there are 2 in Manitoba, there was one in St. Boniface Hospital and one at Health Sciences Centre, both directed by my colleagues, Drs. Christensen and Bashuti. We run pulmonary function testing, which I'll talk a bit more about with respect to ILD. We do echocardiography, which is how this stuff is first investigated with non-invasive ultrasound imaging of the heart. We do imaging looking at all those other consequences within the pulmonary vessels through CT or perfusion imaging. And then ultimately the diagnosis is done through a right heart catheterization, which involves advancing a plastic catheter, usually through the groin or the neck, into the heart, and we actually measure the pressures directly and look for these pulmonary vascular resistances to make the diagnosis. So it is an invasive test at the end, but everything up until that point is a non-invasive sort of screening test. So how do we treat them? I'm not going to get into any of these specifically. You may recognize some of these medications if you or someone you know has pulmonary hypertension, but some of them are also used to treat Raynaud's and the complications of Raynaud's. So it's a similar pathophysiology in terms of how these vessels get stiff within the lungs. So we use PDE5 inhibitors, such as sildenafil or tadalafil, so those fall into that category I was talking about, endothelial receptor antagonists, guanylate cyclase stimulators, and the end stage of this is prostacyclins. All of these are meant to dilate these vessels, relieve those pressures, so unburden the right heart ultimately. The last category there, the prostacyclins, the first two are parenteral therapies, meaning they're not given orally, actually through a subcutaneous or intravenous pump, which patients can become reliant on over time. Selexipag is a relatively newly offered oral, but not as effective therapy in that same class of drug. Anything where you're more concerned that it's a group 2, 3, 4, i.e. relating to some other consequence, not just stiffening of the vessels from the underlying disease, the treatment is to treat the underlying condition. So if it was a consequence of low oxygen levels relating to ILD, we try to treat the ILD as best we can and hope that those pulmonary arterial vessels relax in terms of their pressures. Any questions about pH before I get into a little bit about ILD? Very broad strokes again. I know it's complicated. Okay, maybe. Sure. Quite often, it's the last resort. So all those therapies above it would be the first line therapies and often used in combination up front. It is a difficult decision to initiate these parenteral therapies. It does require a lot of education around, using the tools at home and what to do if you run into problems with it. And it's something that can never be stopped abruptly. So it is a difficult situation to find yourself in, but usually not first line. If they're being used first line, patients are presenting very late and generally not having had recognized disease up until that point. And usually with the intent of doing something. So we don't leave people on IV or subcutaneous therapies forever. Usually the hope is that would be a bridge to something more definitive like a lung transplant. It's not considered as effective. It's not as titratable. So these IV and subcutaneous therapies, we basically give you as much as you need to get there within the limits of the side effects of the medication. But Selexipag has limits regarding bioavailability and dosing. Any other questions? Okay. So again, the manifestations that are near and dear to my heart, so interstitial lung disease, again, also complicated. When we're talking about interstitial lung disease, we're basically referring to the interstitium of the lung, which is where these diseases manifest. That is basically the barrier between where our lungs have air, so the alveoli, and where blood is passing through. So that's the endothelial barrier. So it's a theoretical place that is the interface between oxygen and blood. So you can imagine if there's lots going on there, that interstitium gets thickened or scarred, then the consequence is that oxygen doesn't pass as easily through that barrier. So that's what we often see, is that patients become short of breath and eventually hypoxic because their lungs can't absorb the oxygen as well as they could. The other thing is that scarring results in the lungs getting stiff, so we can't take as deep breaths as we should be able to. So the consequences of those two things working together, again, is shortness of breath, and then the airways can get what are called bronchiectatic, so they don't open and close the way they're supposed to, and that results in coughing and mucus accumulation within the lung. The reason why the interstitium is the area where this happens in connective tissue disease is this is where basically inflammatory cells are recruited. So much like you have connective tissue in all of your organs, including your skin, for example, which is where scleroderma is often first recognized. So you have this connective tissue within the lungs, but the lungs have, I guess, more of a dynamic minute by minute situation that inflammation and scarring should have nothing to do with, and that's why these diseases can have quite profound effects on the day-to-day living. This is basically what it looks like. Again, sorry for the lack of reference here, but the top left is what a CT scan of your lungs should look like. So you can see in the middle, this is your heart, and this is your right lung and your left lung. Most of it is black. That's because it's not dense, it's air for the most part. Your alveoli are filled with air, so they show up black on a CT. Anything that's more white is because of increased density. So your soft tissue, like your heart, is more dense, and this isn't showing the way it could. But bone, for example, would be very white if the phase of the imaging is the way we demonstrate bones. The B here is what scarring looks like. So instead of having this sort of black tissue, these are vessels, by the way. So again, these are normal. They get smaller as you move away from the heart. You'll see that there's a lot more thickening on the periphery of the lung. And this is what scar tissue looks like on the CT scan. The other manifestation is inflammation. So this has a more of a hazy or consolidation ground glass is what we call it, which refers to the sort of texture of a bottle stopper, you know, those glass bottle stoppers. So that's called ground glass, and that's what it looks like on the CT, and that's basically inflammation. And so this is the pathophysiology of how scleroderma results in interstitial lung disease. It's inflammation, which leads to scarring or direct to scarring. And we don't necessarily understand all the pathophysiologic, biologic mechanisms that we get there, but we do understand that generally it is that spectrum of inflammation to scarring. Having said that, scleroderma is only one of about 200 different things that cause interstitial lung disease. So this is the challenge that I have in my clinic is oftentimes patients show up with abnormal imaging and or symptoms, and I need to figure out what is causing their interstitial lung disease. And certainly there is a portion of my practice which has scleroderma, but there's a number of other connective tissue diseases which can mirror scleroderma in the way they manifest in the body that cause ILDs. A lot of them are what are called idiopathic interstitial pneumonias, so we just don't find a cause. The tough part for me is that the imaging, there's overlap between all of these different diseases. So everything looks like inflammation to scarring and along that spectrum. And so what I do when I bring patients into my clinic is I try to triangulate and make a diagnosis either by consensus or by direct biopsy, you know, through a surgical lung biopsy or bronchoscopic techniques. The reason I bring up this slide is sometimes this requires multidisciplinary input. So I chair a multidisciplinary discussion group. I sit down with other respirologists, radiologists, pathologists, and rheumatologists, and we try to come up with consensus diagnoses for these patients. So it is actually quite a lot of work, even just arriving at a diagnosis for interstitial lung disease before you even consider what the therapeutic options would be, depending on what you think the most likely scenario is. So the things that help me decide that are how it's manifesting in terms of the patient experience, what I'm seeing otherwise on exam. So for example, I'll be looking for things like sclerodactyly and ulceration on the fingertips. Some of these disorders run in families, so we're talking about family history. Some of these are exposure related, so I ask them detailed histories about their occupations, their home environments, different, you know, animals that they've had interactions with. Do they have a bird at home, which is a common cause of hypersensitivity pneumonitis. I look at blood work, so obviously there are some autoantibodies that are strongly associated with scleroderma, and if that's present, it's a clue, hey, maybe I'm dealing with a connective tissue disease associated ILD. I'll send them to my rheumatologist to help confirm that diagnosis. And then, as I said, we sometimes will proceed on with bronchoscopy or lung biopsy. Lung biopsy is an invasive way of trying to get tissue to help, again, establish a diagnosis, but ILD is not like cancer, for example, where we have stains that say you clearly have cancer. It's more of a spectrum of pathologic findings. And so we are a little bit hesitant to go there because the yield isn't always what you hope it would be. And it's a situation that's associated, thank you. It's a situation that's associated with a lot of perioperative morbidity. So for patients with scleroderma associated ILD, we often don't need a lung biopsy because it shows up in other parts of the body and we can figure out a way to make that happen. The way it's experienced in scleroderma, in terms of a prevalence, about 50% of patients with diffuse scleroderma will manifest in the lung as interstitial lung disease at some point during their disease course, and about a quarter of patients with limited scleroderma. So you can imagine it's quite common. If you think of all the connective tissue diseases that are out there and are listed some in terms of the ILD associations, it's the one that has the highest prevalence within the disease. But it is not the most common connective tissue disease, ILD. That would be rheumatoid arthritis, which is a much more common connective tissue disorder that's out there. Generally, the symptoms are shortness of breath and cough. And these can be very difficult things to treat. I'll talk about that a little bit more. But oftentimes patients are asymptomatic, and these CT findings are sort of the first suggestion. They have a CT for a different reason, and they notice that there's some scarring in the lungs, and they get sent to me. We go through all this rigmarole. I send all this blood work, look at different things that they may not have noticed on their body, and sometimes that's how, again, we make the diagnosis of scleroderma. In terms of how I, what sort of testing I do for my patients, so it's common for me to order repeat CTs to monitor for disease progression. Oftentimes I'm ordering the echocardiogram, again, to look for co-occurring pulmonary hypertension. Pulmonary function testing is the mainstay of how I screen for disease. So oftentimes people get annual pulmonary function testing, and that's, again, one of the initial clues that maybe there's something going on in the lungs. And then I use it to monitor whether they're responding to treatment or progressing in spite of that treatment or needing to start on treatment. So we do spirometry, which is that hard blow technique. We do diffusion capacity, which measures the ability for the body to take oxygen from the environment. And we do a 6-minute walk test, which is an exercise test that allows us to measure a patient's functional status as a result of, not just the lung disease, but potentially things like joint involvement. And we'll also talk about symptom scoring. So I'm sure you guys are very familiar with symptom scoring as far as the sclerodactyly and skin thickening goes, but we also have scoring systems in terms of the severity of cough and the severity of shortness of breath. And that's how I decide whether I'm going to treat a patient. So as I mentioned, all ILD sort of falls on the spectrum of inflammation to fibrosis, and therefore the treatments are about suppressing the immune system to reduce that bad immunity, or trying to tackle the scarring cascade that happens as a consequence of that inflammation. Over the last 10 years or so, we've had 2 anti-scarring medications or antifibrotics. One is pirfenidone and the other is nintedanib. They are known formally as Esbriet in the case of pirfenidone, and still as Ofev for nintedanib. These were the 2 anti-scarring medications we use for idiopathic pulmonary fibrosis, which means lung scarring of unknown cause. So that's the first indication we had. We now have an indication for really any progressive fibrosing ILD, and specifically have evidence for Ofev for the treatment of scleroderma-associated ILD. We don't have the same indication with pirfenidone. So as far as anti-scarring medications go, we really just have the one. Yeah, so that's nintedanib. Correct. Yeah, so I'll talk a little bit about what the evidence is for these, not in great detail because I don't want to get too distracted. But this is basically my treatment cascade for ILD associated with scleroderma. So as I said, we want to establish whether there's a diagnosis and monitor for the trends. We look for progression. There are some high-risk features that are associated with worsening disease progression. So if you've had a recent diagnosis of scleroderma, and ILD is one of the manifestations of that disease. If you're starting off with a low vital capacity, that's what FVC stands for. Or if you have a greater extent of lung involvement on the initial CT, we think that you're more likely to progress quicker, and we're more likely to start treatment. And that usually, still in 2022, at least in my clinic, is starting with mycophenolate, which is that immune suppressants medication. So we still think that the fibrosis is being triggered by, inflammation or bad immunity. So that's still the first step. If there's progression in spite of that, and it's predominantly lung disease, then I'm more likely to reach for the anti-scarring medication at that point, particularly if it looks like a scarring type disease on CT. If it really looks inflammatory, maybe I'm not reaching for that as the next step. If there are other disease targets that we want to treat with better anti-inflammatory medications, then I might suggest to the rheumatologist, maybe we'd be better off using tocilizumab, rituximab, or cyclophosphamide. The last one is a relatively older drug. The first 2 are considered in the realm of biologics. You may be familiar with them to varying degrees in the room. If despite these approaches, we are still seeing disease progression, then that's when we might look at transplant, be it a bone marrow transplant, which is a relatively new avenue of treatment for scleroderma, as you probably all know, or if it's a lung-specific transplant we're looking at, we might look at an organ-specific transplant with a lung. I'm not going to get into these, but this is sort of where the evidence is coming from. Mycophenolate has been studied as compared to cyclophosphamide, not against placebo, which is an interesting concept. Most drugs are approved for use based on them being used in a randomized controlled trial against a placebo. And I think mycophenolate is still considered an off-label use, like it's not an approved indication, but it's a very commonly used drug, and it's not super expensive. So, we don't have to go through a lot of hurdles in terms of prescribing. And basically what we saw is that it was equivalent to cyclophosphamide in terms of stabilizing FVC. So this is a physiologic measure. We're trying to slow down the restriction of the lung, because again, that scarring results in the vital capacity dropping and us not being able to expand our lungs properly. In comparison to that, the evidence that we have for nintedanib or OFEV, and this would apply to all the indications that we have for OFEV, is that it slows down progression. It doesn't really result in disease stabilization, at least over these relatively brief studies looking at 1 to 2 years of treatment. So from an extension of that, you can kind of see why we still probably prefer reaching for the mycophenolate, because we prefer stabilization rather than slowing. And in the case of OFEV, with all these scarring types of lung diseases, the expectation is you will progress, but we will slow that progression down. So it's not a cure. And that's a difficult thing for patients, right? Because everybody wants the disease to stop. And for a lot of patients, that is, these are all averages. So for a lot of patients, that is actually a pretty dramatic slowing to the point where they get stability for quite a long time. But the expectation is that at some point things will progress, and we're still going to have to look at those other options like I talked about. In terms of managing symptoms, that's certainly a more difficult situation for us. So in terms of shortness of breath, at some point patients may need supplemental oxygen, and of course that can help with that feeling of being short of breath. Cough is much more difficult. So in that case, we would be talking about some medications that have their own side effects, like opioids or antitussives, inhalers in some cases, particularly if there's an overriding asthma or emphysema because of smoking. Pulmonary rehab, I think you guys talked a little bit about pulmonary rehab today, if I'm not mistaken. So that's a great tool in the toolbox for patients who have lots of functional limitations as a result of their lung disease. And that's true about pulmonary hypertension and ILD. We also want to make sure that we're ruling out alternate causes. So I just listed a bunch of things that can cause cough, and a lot of these things are co-occurring disorders for patients. So we have to consider that it's not necessarily just the ILD, and maybe there is something else that we can provide an intervention for. In terms of prevention, again, a focus of every clinic visit that I have, we talk a lot about vaccinations. So the things that cause ILD to deteriorate and flare are infections. So in 2022, that means COVID-19 vaccinations being up to date, annual influenza vaccines, and pneumococcal vaccines as being the main, tools in that toolbox. We also talk a lot about reflux, and this is of particular importance with scleroderma, as I mentioned. So if reflux is present, we try to reduce the acidity with antacids at the very least. And that's true of all ILDs. That's not specific to scleroderma, but scleroderma patients have a particularly high risk of that, and that potentially contributing to their disease progression. We try to address exposures. So if there's something else that we're concerned may be triggering the ILD that's not just related to the underlying cause. Of course, if patients are smoking, it's another thing that you want to address within those clinic visits. And one of the other things that can actually trigger flares or exacerbations of these diseases are things like elective surgeries. So we have to be careful not to add shear stress on those with a ventilator and that sort of thing. So we're often involved in whether or not surgery should proceed based on our assessment of their lung disease. It's pretty rare for scleroderma-associated ILD to flare. This is much more common in other types of ILDs. But if they do flare, we look for a cause. So quite often that's basically ruling out infection or treating it empirically. And oftentimes this results in quite a bit of need for oxygen, so usually a hospitalization. And the mainstay in non-scleroderma-associated ILD to treat flares or exacerbations is steroids. And as you may know, steroids are something we're concerned about using in scleroderma because of the potential for scleroderma renal crisis. So we don't have that tool at our disposal for this. So again, rare circumstance, but one can be associated with lots of sort of post-admission morbidity. At the end of the day, quality of life is one of the things that we try to emphasize as disease progresses, and the impacts that we have on that are pulmonary rehab and of course psychosocial support groups like this, coming together and trying to support each other through the manifestations of our disease. And at the end of the day, palliative care is a really great resource for patients who particularly don't have other options in terms of addressing symptoms in ways that we can't in our clinic. They have better tools, they're better equipped in terms of the resources, the allied health resources that they can bring into that clinic space and those outpatient visits. Hopefully though, if there is progression, we get to that point when there's still a window of opportunity to consider something like a lung transplant. And so the things that go into a lung transplant evaluation are how quickly the disease is progressing, how severe that progression looks like, how old the patient is, unfortunately, is a reality of that assessment. There is a bit of an age cutoff with our transplant center in Edmonton. What other organ comorbidities or what other manifestations of the disease one might have. So for example, if you had lots of esophageal dysmotility, we were to transplant your lungs, that risk of reflux is constantly there and is a threat to the new organ we would be transplanting in. So these are all things that the transplant center takes into consideration, and then they discuss it with the Edmonton service and then come up with a decision about whether a patient can be listed. And quite often that's a patient-directed thing where it's not something that they would want simply because it's the biggest surgery that anyone would ever go through in their life, and it's pretty daunting to consider after all the education provided by that clinic. And that's a different clinic in the same space that I work in. But that is unfortunately the end point for a lot of patients who have interstitial lung disease, regardless of cause, including scleroderma, although it carries a much better prognosis than some of those idiopathic ones where we really don't know what's driving the scarring. That's pretty well all that I had. I don't know how much time I took. I hope I wasn't too long, but I'm hoping to entertain any questions. I'm sorry if I got too in depth or not in depth enough. I'm not really sure what the right mark is. So COVID is challenging. Obviously. The 2022 experience that I've had with COVID is that the patients who are doing the most poorly right now are the ones who are immunosuppressed, which is a reality for lots of patients with connective tissue disease, in particular rituximab and mycophenolate. I don't know if it's just because they're more commonly prescribed at this stage, but I do see that the manifestation of COVID in those patients, regardless of vaccination status, is worse. And the mainstay of treatment with COVID is to immunosuppress. So we give patients steroids and sometimes tocilizumab in the right circumstance. We do have these antivirals, which are relatively recent tools, but I haven't seen them be dramatically effective for that patient. Anyone who's got interstitial lung disease, regardless of cause, is at higher risk because, as I said, any infectious trigger can cause an exacerbation or flare. And then my job, and I see lots of patients post-COVID, regardless of what their pre-COVID status was, is to try to sort out what is disease progression and what is infection. And a lot of times it's a waiting game. So we sort of will repeat CT scans and evaluations after a few months and see what we're left with. And a lot of times COVID alone will self-resolve in terms of the lung manifestations. You'll be left with scarring. And if you're still dealing with lots of inflammation at that point, it's likely that the disease process for a patient with ILD has been unhinged by that infection. So it's a big challenge. It's a big challenge in an inpatient setting, and it's a big challenge in outpatient follow-up. And those two things look very different. So a lot of times in hospital, we're giving lots of steroids to try to mitigate the inflammation. And post, we're trying to sort out what are we left with, is how much of this is COVID and how much of it is maybe something else that was under-recognized or not recognized before the infection. I don't know if that answers your question. Yeah. Yeah, so that was an option before Omicron. We had the monoclonal antibody against the spike protein, but Omicron mutated that spike protein in the virus, and it became no longer a tool for us to use. So in Manitoba, we had a very brief window where that was an option for outpatients or inpatients. So now we're largely relying on remdesivir in terms of COVID-specific treatment, and then trying to suppress the inflammatory cascade that comes from it. Yeah. So there are actually specific parameters we use. So we usually start with a blood gas. So it's an arterial poke in the radial artery. And if your oxygen, what's called the PaO2, which is the partial pressure of oxygen in your artery, is below 60, which corresponds to an oxygen saturation from the finger of about 90%, then you can qualify for funded oxygen from the province at rest. If that doesn't qualify you, then we'll often put you through exercise testing. So that's that 6-minute walk test. You basically walk with and without oxygen. And if you drop your oxygen if you drop your internal blood oxygen without supplemental oxygen, and then we give you oxygen and that improves and your exercise improves, then you can get exertional oxygen. So those are the two main parameters we use to establish whether that's the point that you're at. And obviously we're trying to adjust treatments to improve the situation as well at the same time. So generally speaking, it's 70, which is young. In Toronto, that bar is different. And I think that the lung transplant community worldwide is trying to move away from an age cutoff and looking at it more of, what other health concerns might go into that assessment. So I would say that we are transplanting patients in Manitoba who are of pristine health, other than the organ we're talking about, after the age of 70. The whole idea is that we want your age expectancy to exceed that which we hope to provide you with the lung. So if you've got other factors that are going to limit your life, it's a very valuable resource, and it's things that people wait for years. And so we don't want to get into a situation where we're only giving you a very short window with the new lungs that you're being transplanted with as a result of another health consequence that was not appreciated or appreciated and transplanted in spite of. That makes sense. The 70 is a really hard thing to digest as a medical community and as a patient. And that's why it's not an absolute. There are very few absolute contraindications to transplant. It's just one factor that we would consider. Yeah. So averages, right? There are complications that can happen immediately after a lung transplantation that can be life limiting. And then there are ones that we think about more in the long term. So rejection. So patients who get transplanted ended up on, you guessed it, immune suppressing medications to help limit the rejection of the new lungs. And that's why you need to be matched very specifically with a donor that has similar blood types. And we look at your antibody profiles and that sort of thing. On average, though, the clock starts over and gives you an average of about 7 to 10 years after transplantation, which significantly exceeds your life expectancy with the lungs that you have at the time of transplantation. Yeah, I think that risk benefit still looks in favor of the vaccine. So being unvaccinated or having ineffective vaccination because of medications you are and then getting COVID is more risky than probably being a week or two without treatment. Really depends on which medication you're talking about. And the rheumatologists, a lot of these guidelines are coming from the rheumatology societies, so they're probably better versed in terms of every individual drug we're talking about. But the whole idea is to try to allow you to build up some antibody as generated by the vaccination. Most of these medications take months to get into effect. So mycophenolate, for example, we don't think is effective until you've been on the drug for 3 months. So you can imagine that being off it for a week or two is probably of not great consequence. We do delay rituximab infusions, for example. These are drugs that are given every 6 months, generally for connective tissue disease. So we'll try to time the vaccination to be at that 5-month point right before to get your next one. But if you're just starting rituximab because of disease
progression and you want to delay that for vaccination, that's a risky time period because you don't have the 5 months of drug before it. So it really depends on the situation and the drug. Yeah. Yeah, so I am excited about antifibrotics. Don't get me wrong. It's the bread and butter of my practice in terms of the therapies I offer that are specific to my practice. All the immunosuppression decisions are generally jointly made with rheumatology, so it's not as much me as it is a team. But antifibrotics, generally, the other doctors you would interact with would defer to the respirologist because we've gained a lot of experience over time. The reason why I'm not super enthusiastic about them is because, I would love a drug that reverses what happened or completely stops disease progression. And there are significant side effects associated with these medications, and they're very expensive. So if you think about all of those factors that go into a treatment decision, it can be very challenging. And the reason why maybe I don't seem enthusiastic is that we don't always have success with it. And it is very much a joint decision between myself and the patient to embark on that pathway. And sometimes patients don't have good experiences because, again, the disease progresses or they don't tolerate the side effects. So I try not to pump it up too much and say, like, this is going to be a game changer for you. But you're right. It has been a game changer in terms of scarring lung disease in the last decade. And it only became approved for scleroderma or other progressive fibrosing lung diseases in June. And the reason why I'm giving you kind of a detailed deliberation of what that looks like is that we've had it for years for IPF. And any drug that comes as an anti-scarring medication for interstitial lung disease will first be studied and approved for idiopathic pulmonary fibrosis. So it took quite a long time for it to be studied and then approved and then paid for other ILDs other than IPF, idiopathic pulmonary fibrosis. So there are some one or two drugs that are in phase 2 to 3 development that are exciting for IPF. What that means for other types of inflammatory or scarring interstitial lung diseases, probably years away. But I think we have more tools for scleroderma associated ILD than we do for IPF. So IPF, that's all we have is that anti-scarring medication. There's nothing else approved or effective. But we have, more and more indications for biologics like tocilizumab and rituximab and really good, interesting, like disease modifying data, which is not the case with antifibrotics. So that's why it's still not first line, because we do think that there are other medications in the immunosuppressive category that are more effective in actually modifying the disease trajectory rather than just slowing it down. Okay, yeah. So I was asked if tocilizumab is something I've prescribed here. I haven't here. It would probably be accessed through the rheumatologist. So that would be a joint decision. And, generally speaking, you want to see things not working before you get to that point. And quite often they're using other biologics first for non-pulmonary disease. So it's an interesting negotiation between different organs and, the relationships we have. And that's why I think a multidisciplinary clinic in the long run would be a really good thing for the province. They don't. And again, it ends up being a bargain. So something that I think is good for the lungs may not be good for the joints or the skin or the heart. And I'm not an expert in those things. And so I will offer suggestions in terms of the next step. But in terms of accessing these biologics, most of them are accessed by rheumatology. So I don't have approval to prescribe rituximab or tocilizumab. So it would be a joint decision, often a recommendation from myself. The things that I personally prescribe would be things like mycophenolate, Imuran or azathioprine, certainly the antifibrotics, steroids in the right circumstance, but the biologics are sort of restricted access and joint decision. So not to date, but certainly I did in Toronto. Yeah. That's a good question. My sense from the rheumatologist is that they don't have a lot of barriers in accessing these medications, or maybe variable barriers. So some are more easily accessed than others. Rituximab, when I was finishing my training, was very limited access. And now they can prescribe it in many conditions without really much restriction. It's the same thing with antifibrotics. It used to be a very difficult thing to prescribe, having to provide lots of evidence and rationale on every case that you're prescribing it for. There's province by province variability, but I haven't to date felt like there's a medication that's really good for this disease that I can't help prescribe with a rheumatologist. So tocilizumab in particular is one that's become much more available in recent times, and I think part of that had to do with COVID. So we suddenly had an indication that was a very broad disease, like very prevalent disease, and it became prescribed much more easily in inpatients where I have a lot more experience with the severe COVID illness and second and third line treatments. So I don't know the answer to your question. I'm not aware of barriers for the rheumatologists. That's probably a better question from them. Certainly, I feel like I have good access to antifibrotics, which is where it's coming from my office today for this type of disease in the right patient. Any other questions? Yeah, it's a good question. So I think COVID is still a distinct illness from a lot of what I was talking about in terms of the 200 diseases that I look at. I mean, really, we're talking about a couple dozen common ones. And for the most part, I think the ILD end stage of COVID is a post-infectious process that stops. So early on, we were really interested in studying, should we be giving anti-scarring medications, antifibrotics, Ofev, nintedanib, or pirfenidone to patients who have COVID. And they started recruiting for these trials in Europe. But then vaccinations became available and the severity of COVID dropped and the recruitment into some of these trials went with it. So that trial never finished recruitment. And at the end of the day, what I've seen kind of 2 years into this pandemic is that most patients, if they develop scarring, it doesn't progress in the same way I see with idiopathic pulmonary fibrosis or connective tissue disease, ILD. The situations that I was talking about with, the complications of being on immune suppressing medications, like those numbers are probably too small for us to ever gain a lot of knowledge about the right way of doing with it or dealing with it, and it's a case by case basis. So kind of a complicated answer to your question, but I think the pathophysiology of COVID is very distinct from what we know about ILD. And I think we've gained experience with some of these drugs, but in terms of it being a game changer for how we treat ILD, haven't seen it yet. Yeah. All right. Looks like lunch is on its way in. So thank you all for inviting me here. I really appreciate it.
So yes, thank you very much, Dr. Colbourne, for being with us today. It's a very challenging disease and you've given us all a little bit of hope and for the future. So we can offer you this small token. Thank you for making yourself available and please stay for lunch. So this concludes our AGM event. Thank you everyone for coming and please take a moment to complete the feedback form that was provided to you when you came in. Please leave the forms on the reception table and you can leave your name tags behind if you don't want them. We'll maybe repurpose them. And lunch is being served in this room and please help yourself. And thank you to our sponsors, Boehringer Ingelheim and Janssen for making this event possible and to the team here at Canada Inns for making our event a success. Thank you.